now they've made it into medical, and now it's skin camouflage. You can see, guys, all these terminologies that's coming out there. It's all rock and roll. Hello, everybody. Thank you. Welcome. And Mustafa, thank you for joining me. This is Hal, your occupational therapist, and I am with Maria.
Hi.
Hello, Maria. So we're just having a random conversation. It's a Saturday morning, quite cloudy outside. So we're not in any clinical setting at the moment, Maria and myself. We were just catching up with some of the things that's happening.
So what are we talking about?
Just an update. Maria has just been to a hand therapy training course for pediatrics. And we're just catching up, really. What was it like?
Intense.
Was it?
That's intense 3 days of information overload. Really good.
Brings you back to memories of being at the university.
It reminds me of a lot of things to revise on, but it's the feeling of being back in university again and learn and studying. And the exams, oh my.
It's not a multiple choice question.
No, it's not. It's a lot of cases and explanations and essays and enumeration. There's a few that's quite easy, and there's a few multiple choice questions too, but it doesn't just say it. You have to justify. Like, there's a choice of this, why. There's always a why, and you have to explain why. And
you don't just have an option because it is what it is.
You have to justify why you chose that. Is it true or false? Why did you say it's true? Why did you say it's false? Things like that. It's a lot of writing. My fingers hurt. I don't have the writing tolerance and stamina anymore. It really hurts.
And that is the one that the course did not factor in, isn't it?
Yeah.
So people are going there as pediatric hand therapists. Obviously, you're there because all the rheumatology component, and they have not factored in that you may have rheumatology.
Yeah, that's true. I should have said, I would put that as a feedback. Because as OTs, we assess for those things, and we even recommend adjustments, reasonable adjustments in schools for taking exams. And yet we didn't do that in there. Because really, halfway through it, I couldn't write anymore. But I just carried on because I have to. It would have been easier to type. But that's a good learning for me, because I do this as a job. I assess and actually recommend stuff, and it's just an evidence that that's actually right. What I'm recommending is correct.
Yeah. And it's always very handy. I know it's not nice to be able to fully empathize with patient because you have the same condition. But in some ways, a clinician who can truly empathize with their patients are those who really have been through the same ordeals, isn't it? Like yourself, you have
rheumatoid
arthritis, so you can relate to children. You can relate to anybody who's got complaints about arthritis, both young and old. Because I'm the same. I have arthritis myself. And every time I come across with some elderly patients and clients, and they're complaining about how difficult things are, while excuse for being less tactful about it. Sometimes other clinicians are not very empathetic of what they're going through, and they'd always blame it onto people's psychology.
Yeah, psychology.
Yeah.
Because they can't see it. These are things that you can't see. It's nothing to show that you're actually struggling, but with just one look, you're fine, you can do that.
But it is very painful, and I can fully relate. I can even enumerate some of the problems, and then every time I say these things to patients, you can see that their face lights up because somebody can truly understand. And then you will have some therapists, like physiotherapists, for example, who give them exercises. And I know there are some benefits to exercises for stretching and everything else, but sometimes it can be detrimental too. So not everything can be treated by exercises.
Exactly. There has to be a balance between activity, exercise, and rest. Because sometimes you just need to have a break, to reset, and go back to it again. But not everyone gives you that opportunity to manage your condition. Anyway, so that was the
We started
the
talking about
exam.
arthritis.
Arthritis now.
That wasn't planned.
Yeah.
Okay, moving
The
on.
exam.
The topic was the hand therapy course, was it?
So I was saying there's so many topics, and it was actually, as I said, it's good. Nothing bad about those things, but it would have been. It's just so generic. It would have been good to separate them, do a course on each of them. But it's a good overview of everything. One thing that is stood out for me, scar management.
Right.
I didn't realize that. I know I do that at work, but it's more just, okay, it's a scarf. Here you go. You can look into ointments or stuff that you can put in your scarf and massages. That's about it. That's as simple as I would go with it.
Because
But-
normally a scar management, from my experience, is, I guess, physical therapists would be advising on that because it's something physical. And you do the massage so that you can have microcirculation going on, all of these things. And then as an occupational therapist, yes, person will need to know how to manage their own scar. So that's where occupational therapists come in under
And-
the health maintenance and soft tissue.
And also at the
yeah.
very beginning of it, so you intervene soon. So that's a good thing. As soon as you can, as soon as the wound heals, start to prevent adhesions and to promote movement, to promote more joint mobility and function. So that's good. But I didn't realize there's so many things going on about it now. So many things you can use to manage it.
Really?
Yeah.
Like things that you can put into it? Or?
Yeah. Like, there's a gel, there's a silicone. Oh my gosh, I don't remember the names, okay? But I have photos of those. There's all the products that you can put. And the assessment tool. So many assessment tools, although not all of them. There's a couple that is recommended. It's just something that I won't normally do. I would assess a scar by looking at it, describing it.
But there are stages of
But there's
scar.
stages of scars and
Yeah.
also types of scars and what do you look at, and then
Callus
the numbers,
formation.
and then there's actually numeric assessment. It's good. It is good. It's a good thing. It's good to know. But I don't know if I can apply it. I should.
Yeah, I think when you see somebody and you're at that stage, rather than describing the scar, you can describe scar via the stage because it's all visual inspection, right?
Yeah.
You can do that. Let me see if I can recall some of that. Okay.
There was I have it in my notes. Not all of it I could remember. It's all in my notes. So that's one. The other is management. So if the problem is cosmesis and the look of it, and sometimes they're just people who are very conscious about it. This is very new to me. The skin camouflage is a very posh name. Skin camouflage. And
Skin camouflage.
Yeah.
So that's a technique.
Yeah, it's a treatment. Well, it's like
Skin
strategy.
camouflaging technique.
It's just a skin camouflage, what it's called. And
So what do you do? I'm
can-
a therapist. I'm going to give you skin camouflage.
Yeah. And you assess it. And basically, it's a makeup kit. But it's a skin camouflage. And
For the hands, obviously, it's not going to be a face.
that could be anywhere, apparently.
Wait, you were in a hands
I know,
training.
it's a hands training, but you can use it. It's a skin camouflage. Who does it? Whoever wants to do it, basically.
These
It's
are-
another strategy, it's another technique, it's another thing in your toolkit. And what it is there, it just gives you all this variety of stuff that you can put in your toolkit as an OT. So skin camouflage is a new thing that I would never think.
I will have to add that into our unique selling points and
Wow.
some treatment. Skin camouflage
Mm.
is one of the technique that is actually being utilized now. Definitely not at the time during my training and yours. So these are some of the words that people have been using. And so there's no special makeups to it, not a medical makeup.
Nothing.
So it's just something that you can go like
There is some-
L'Oreal or
They didn't say any brands, nothing brand. The one in the video, that's a good question. I didn't ask them that. What's the brand? Where do you get them from? But they sent us, they gave us a link to a website where you can look it up. So
Okay.
they would probably have more information. That's why
Okay, we're going to do that. We're going to follow that up.
skin camouflage. And there's a video who a therapist talking to patient. Well, no, it was an interview, and it's not a patient, but just to demonstrate how it works. So basically, what it is a few colors of skin types, colors: brown, black, dark. With fairer skin would have the fair choices of colors.
So like a palette of
Yeah,
skin
like palette
tone.
of skin tone.
Wow.
That's a good word. And then you try on the skin, and then you rub it, and then see if that's the right skin tone. Try another until you get the right kind of tone.
That is so normal.
That's so Then you put a setter on top of it, so it doesn't smudge or it doesn't go away so quickly. So even it's waterproof, so you can wash it. As long as you don't rub it. It's hard for the hands because you do a lot of hand washing.
Yeah.
But you can, as long as you just pat dry it, you don't wipe it or rub it. That's the technique. So mostly these are for those who are gonna wear something cosmetics, like in the neck or in the arm at the back, where you will wear something that that will show it. So you put that.
Wow.
So skin camouflage.
And do you think NHS is focusing on these things?
That's a good it's a really good question that was asked at the same time on that training, because apparently you can ask your GP for it to prescribe it.
What, skin camouflage?
Yeah. Because what they do, so in that assessment, they find that, oh, this is the one for you. Okay, I'll write to your GP. So you actually can write as an OT, or somebody whoever did the assessment writes an OT. This is what the patient needs for this reason.
Okay.
To cover the scar for this reason. And then they can ask. But not all GPs would fund it. But it is something that you can write as a therapist to the GP. And I was like, wow. So some GPs actually pay for it. Yeah. But it depends on the GP. What's going to be your clinical reasoning for it?
For well-being,
That's
body image, self-concept, psychological preservation, all of these best-selling technologies. So scar management is one.
Scar management and camouflage.
Camouflage
Skin
technique.
camouflage. I don't know what's it's technically a concealer.
A concealer. So back in the 90s, 80s, it's called concealer. Now they've made it into medical. And now it's skin camouflage. You can see, guys, all these terminologies that's coming out there. It's all rock and roll. So with regard to scar, so I'm just looking it up. Yeah, so scar stages. And we're referring to the phases of healing. And this happens through after an injury, after a surgery, or any skin damage, and then scars will then definitely evolve, and it evolves over time. And there are some stages to it. So the first stage is the homeostasis, which is the immediate response. And this is the first stage right after the injury, where the body stops bleeding by forming a blood clot. So it's like technically wound healing, isn't it? Homeostasis, there's a balance. The next stage would be inflammation, and this usually takes 1 to 6 days. So after the homeostasis stage, you have the inflammation stage, which is usually taking from 1 to 6 days. And in here, because it's inflammation, there's redness, there's tenderness, it's warm. The area is obviously warm. And the immune system is working to clean the wound to prevent infection. So here, the white blood cells are actually rushing into the area, and this stage can last for several days. So inflammation days or inflammatory phase. Next stage, which would be from day 4 up to day 24. Yeah, this is proliferation day, proliferation stage, where the new tissue or collagen starts to form. The wound's beginning to close. So 24 days. So from day 4 all the way to day 24 is a proliferation stage. Collagen build up, the wound's beginning to close, and the scar tissue is then becoming thicker and thicker. So here, the blood vessels, the skin cells, they regenerate, and the wound is actually contracting to reduce its size. So there it was, the third stage, which would have been the proliferation stage. And then the last one would be the maturation or the remodeling, which happens from weeks to years. It can happen depending on the severity of the scar. And over time, then the scar becomes flatter, paler, and softer as the collagen fibers are rearranged and these collagen fibers are strengthened. And this is the longest phase, and the scars will continue to change over months and even years on this phase. So really with scars, it often starts being red or purple, but over time they become lighter in color and it becomes less noticeable.
Does it say there how long, when is the optimal time to move it or to do massaging? I think, as far as, if I'm not mistaken, if my memory is working well, I think they recommend as soon as the wound is healed, you start mobilizing.
Yeah.
And as long as tolerated, to allow it to heal in a good way or form in a good way.
Think after the inflammation stage, where it's the proliferation
Well, that's
stage.
about what, 9 to 10 days?
So inflammation stage is 1 to 6 days.
Yeah, so around 9-10 days, you can start moving at them.
And the proliferation stage is from day 4 all the way to day 24.
So around that stage, really.
But you have to be very careful.
Yeah, the stitches would still be so fresh.
Yeah, and you can actually tear it. Proliferation is cells are building up and it's trying to, like Lego, build itself up. And when you do that and you start to really move it, it's a bit mechanical movement. It's a bit tricky, isn't it? If you try
So
to
what
think
you
about
do, for example, on the incision part, you don't move the top layer so much. It's more the deeper layer you're working on, so it doesn't stick. And more just making sure it's loose enough. I think the top, you be careful with it because that's you need to keep the integrity of the stitch.
So sustained pressure, you can do that. Wide, sustained pressure rather than focal pressure. Wide pressure, palm of hand, something that covers the entire wound itself, and then you just press it. So some of the
Gently
techniques,
within pain.
yeah, gently as pain tolerates it, and then you just let go, press, and then you let go. So this will then call for therapeutic handling, some of the techniques that is being used in urology, where you would do that, and sensory integration, but being mindful that it is the wound.
And also, of course, at that stage, it will be sensitive.
Yeah.
So resensitization and is also part of the goal there. And just starting at the same time, you want to work on the scar formation in a good way.
Okay. So there you go. And on the remodeling, maturation and remodeling phase, where the scar is now getting lighter, it's getting lesser and lesser. This is now when, after 24 days, you can start talking about concealers or scar camouflage. Scar camouflaging technique. Okay? Scar camo technique. Okay? Scar camouflaging. Wow. And there are some GPs that will pay for it.
Apparently. You can prescribe it as a therapist to say this has been tried, this works, this tone color palette for.
GPs are very powerful
There they
in
are.
terms of the healthcare because they're like small NHF. And everything that they would do in relation to a patient in the same way as NHS would be doing it. There are tariffs. That's why some of them, they don't want to do a lot of investigation straight away. They want to minimize because every expense is chargeable to them.
Yeah. Exactly.
Isn't it?
They pay for everything.
Yeah.
That's why they try to do as much as they can within their GP practice. Because once they go out to specialists, that's a lot. That's something they pay for each patient. But each patient has a budget.
Yeah. Everybody has a budget from the government.
Exactly.
Yeah. And this is the one thing that we've not been allowed or we've not been informed. These are the things that we need to know as a public or as therapists and as clinicians.
Mm.
Because if you do that, I was just thinking, maybe I can just put up my own private practice attached to a GP, isn't it? Like general OT practice. Is that a possibility? You go in, but who do you charge? Primary care.
Mm.
And then
But they
you,
don't know about this. They don't know about our service, what we can provide. They would pay for physios. So like our local GP, they have a connection with the physio practice.
are they?
So before they send you to a specialist to have, for example, you want to be referred to orthopedics because you have frozen shoulder and you want to explore that. Wow. Before they send you there, you're sent to a physio first to try this block of session, and they have their own connection to physio practice here at private physio practice, and they pay for that. The GP pays the private practice to look at you, see you for this certain amount of sessions, get you better, and with the hope that prevents you from going to an orthopedic consultant for that type of treatment. It might work for some people, but for some it doesn't. So you have to be proactive in asking for it. Because otherwise, they just assume you've done physio, you're okay. But after a while, you gave up. That's it. I'm done. Nothing happened. You have to go back to them to ask to be referred. They won't follow you up because if they do, going to spend more. Yeah. So in the end, and also an OT, we can probably do that too. What can we do to prevent? Because that's the I think that's the model they're working on. Prevention to go to a specialist. So as an OT, how do we prevent something in an effective way? It could be detrimental for some people, but it's up to you in your assessment, your practice, and your treatment, isn't it?
Yeah. That's another avenue for any of you guys who's listening. Take heed and listen to these potentials and possibilities. It's serious enough for us to pay attention to the things that we can do, things that we can promote with regards to our service. And having said that, with service, I've always been a huge advocate of our intervention and our input. And I always believe that anything we do matters and has an outcome. And that is the mantra that I share with the team. And basically, you have to know what you're doing. You have to label what you're doing, because anything that you would do, there would be an associated outcome to that. Like that concealing. No, it's camouflage. Skin camouflage techniques. That would be something. Okay. Wow, we've gone through a lot of conversation, had a lot of discussion. Skin camouflage technique. The other thing that I find, when we were having our previous conversation before the education per se, it just calls for me to revise on stages in the development of the hand, isn't it? I did not realize that a child's hand only has decapitate.
So initially when they are born, they would only have decapitate. Actually, it develops from 1 to 3 months. Decapitate.
In vitro?
1 to 3 months post.
After. So not
The-
in the uterus.
I don't think so. So they're
In
just
utero, not in vitro. In utero.
in utero. No.
Not in utero.
So it says in that training that decapitate. They showed us X-rays of children's hands, and 1 to 3, there's just decapitate, and then there's the tiny.
Little seeds of
Not even the others.
carpal bones.
Yeah, there's what's the other one? Triquetrum.
Yeah.
Yeah, so decapitate.
Trapezium, trapezoid, triquetrum is the next biggest one.
Oh, the hamate as well. So the hamate is next to the decapitate. The hamate's a tiny speck. And that's almost all the same time. Those 3, capitate, hamate, and the triquetrum on this border. So it's all on this hypothenar side that starts to develop first.
It's
So
on the hypothenar side, is it?
Yeah, it's the ulnar side. So there's a kind of
Really? So
on
that's why, that explains why power grip comes in first before the precision grip.
Yeah. And then towards the later part, 4 to 6 years, is it? They start to have to develop what's in here?
Scaphoid.
The scaphoid, trapezium, and the trapezoid on that side.
Really?
And the last is the pisiform, which is 8 to 12 years.
Which would have been just a supplement because that's the insertion of
The
the
FCU,
flexor
carpi
carpi
ulnaris.
ulnaris, isn't it? And that makes it a little bit more stronger.
Yeah.
That's amazing, isn't it?
Yeah.
Okay. Let's have a quick recap and review. The first ones would be on the lateral side or on the radial side, right? And what would be the first bones?
The ulnar. What do you mean?
Oh, yes, the ulnar side, which would have been, you'd find the hamate trapezoid.
Yeah.
Yeah, that'd be the first one.
Triquetrum.
Triquetrum.
The cup is a keystone, so it's in the middle. But most of the other carpals, like as I said, the hamate triquetrum, they form the border side, the ulnar border side. And they form first before the radial side, which is the scaphoid, trapezium, and trapezoid. It's more of a finer movement. So that's why the gross movement, the power grip, develops
comes in first.
So that's all the gross movements and the power. And then at the later stage, your more finer movement of the finger, the pincer grip and the tripod grip and all that becomes more developed.
And that is technically from the ossification and the development of these bones. It gets more prominent from what age? From age 6, you say?
4 to 6, yeah, something
around that time. And then the last that would be developed for strength would be the pisiform, if you want to pronounce it in this part of the world.
Pisiform.
It's pisiform. Pisiformis, piriformis, not pyriformis. Because it's Latin, so it should be pisiform.
Yeah.
Yes, we're here, so it's pisiform.
I just came from a training in England, so it's pisiform.
Pisiform. Okay, so that's cool. That's very interesting. Good. So that's that's a very good take home.
Learning, yeah.
Actually, after take home, because you took it home and then you shared it with me. Now we're sharing it to whoever is listening out there, okay, who finds OT conversations interesting. I hope you enjoyed this session, guys. Until next time.
Bye.
Bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.